more Part A of Chapter 23. I'm looking at Slide 2. We're ready to start talking about the pharynx and the esophagus and the process of swallowing, which is also called lentition. The esophagus is a muscular tube that's only used to transfer food from mouth to stomach. It's just a chute or a slide. And, well, I guess slide is non-active. This is active. And it primarily propels food via peristalsis. It's kind of like the poster child for the peristaltic process. And at the top of the esophagus, where it is sort of transitioning off of the pharynx, we have a sphincter. At the base of the esophagus, between esophagus and stomach, we have another muscular sphincter. The esophagus has to pierce through the diaphragm in order to reach, obviously, from thoracic cavity into abdominal cavity. And that perforation, if you will, in the diaphragm is called the esophageal hiatus. The esophageal hiatus. Whereas the point at which esophagus meets stomach is called the cardial orifice. Cardial orifice. And the specific sphincter that exists between the esophagus and the stomach is called the gastroesophageal sphincter. And this sphincter is closed whenever we're not actively swallowing. We do secrete mucus into the lumen of the esophagus just to ensure that we have lubrication, smooth ride, if you will, but also to protect the esophagus from any reflux of stomach acid. The esophagus is also kind of the poster child for the four classic tunics that comprise the wall of the alimentary canal. So very predictable in terms of what those tunics are and what they're made out of. Just please remember that the mucosa in the esophagus is made out of non-keratinized stratified squamous epithelium, whereas once we enter the stomach, we're going to transition to simple columnar. Okay. Also, the esophagus features an adventitia rather than serosa per se, as that sort of outermost tunic. I'm moving to slide 3, where we can see much better that the esophagus is a rather collapsed tube, which is absolutely okay, whereas we don't ever want the trachea to act as a collapsed tube. We want that airway to be nice and wide and open. Here's our mucosa, in this case made of non-keratinized stratified squamous epithelium, our submucosa, our muscularis externa, and in this case, adventitia. Moving to slide 4, we're actually skipping the particulars of deglutition, the swallowing process this quarter. I'm going to move to slide 5 and just show you what it is I really need you to know. I'm not going to ask you to list the phases. That's not important, nor is it emphasized in the curriculum. But you should know that the sphincter that I mentioned previously between pharynx and esophagus is called the upper esophageal sphincter. And before we swallow a bolus, so while we're chewing and forming that bolus, the upper esophageal sphincter is closed. Whereas once we move that bolus into the oropharynx and even the laryngopharynx, then we open that sphincter, that upper esophageal sphincter. And I also wanted to remind you that when we swallow, the soft palate and the uvula, they rise to sort of seal off the nasopharynx so that we don't send food upward into the nasal cavity, which, ouch. And the larynx rises up, the epiglottis kind of bends downward, and they meet each other to seal off the trachea. And once we've got that bolus transferred from pharynx into esophagus, now we close that upper esophageal sphincter back up, okay? And we're performing peristalsis, okay? All the while that gastroesophageal sphincter, the one between esophagus and stomach, is closed, okay? And it's not until we move the bolus into contact with that sphincter that it finally does open. So I need you to know generally what's happening. I'm never going to ask you, what's the name of this step or list these steps in order. We're going to move to slide 6 now. Hi. For whatever reason, I couldn't get the recording to come back on. The stomach participates in both chemical digestion and physical digestion, whereas the esophagus really doesn't participate in digestion per se. It's just for transport, just to get food through that thoracic cavity that stands in the way between mouth, which does participate in digestion, and abdominal viscera, which do participate in digestion. And the stomach is going to convert our bolus into kind of creamy, paste that's called chyme. And chyme, at least in the U.S., is conventionally... wow, why is my pencil not working? That's weird. I'll be right back. Okay, it looks like this beastie's working now. What a weird thing to happen. Anyway, I think... I don't remember. I think I was talking about chyme. So, it's fairly conventional to spell chyme with a Y, but this is also technically correct spelling. I just wanted you to notice that on your original slide it's spelled with an I, but I've changed it to a Y because that's how it's typically spelled. And our stomach will have anywhere from 50 milliliters of sort of empty space within to 4 liters of, I guess, Thanksgiving inside. So it's very, very expandable. When the stomach is empty or relatively empty, the mucosa folds on itself to form many, many rugae, and I'll show you rugae in just a moment. Just a reminder that the stomach is attached to both lesser omentum, superiorly, and greater omentum, inferiorly, a little bit more anterior than posterior. Lesser omentum connects liver to stomach, and greater omentum, while it does connect stomach to transverse colon, it doesn't act as much as an anchor as it does as an insulator, a blanket, if you will, as well as preventing twisting of organs. Moving to slide 7, here's our stomach, and the stomach is empty, so I can clearly see the folds that we call rugae inside. The stomach has a muscularis externa that has not just circular and longitudinal layers, but also innermost an oblique layer, so that we have fibers running in 3 directions. And this, smooth muscle fibers, of course, this makes the stomach even more flexible, even more powerful, even more manipulable, so that it can practice mechanical digestion, not just chemical digestion. The outermost layer is considered serosa, although this is an intraperitoneal organ, so technically it has serosa and adventitia. The mucosa here is made out of simple columnar epithelium. And when we zoom way in on this mucosa, we'll see it's actually highly modified. This portion here, where stomach is meeting esophagus, is called the cardia. This portion here is called the fundus, and I remember that because if I'm in a roller coaster car, then it's right about here that I'm about to have a lot of fun. The bulk of the stomach is called the body. I'm making a mess here. Here, lesser curvature, and here, greater curvature. This region in general is called the pylorus. And it terminates in the pyloric valve, and the pyloric valve is established with yet another sphincter. This sphincter is called the pyloric sphincter. And if I were to point it at this region, either on exam 3 or the practicum or the final or whatever, I would accept either pyloric sphincter or pyloric valve. Okay. The stomach connects to, obviously, the esophagus, but also to the small intestine. And it connects to the portion of the small intestine that's called the duodenum. Some people say duodenum. We don't care. It's not an oral exam. Either one's fine. Okay. Moving on to slide 8. And we are going to zoom way in on the mucosa of the stomach. And we'll see that this mucosa is very surprising. There's a lot going on here, and there's a lot to point out. And one of the things that really makes this mucosa look different is that it's interrupted regularly with little perforations that are called gastric pits. And gastric pits lead to gastric glands. Gastric glands actually have many different types of cells in them, specialized cells. And collectively, those cells make what some people might call the juice or the fluid product, the secretion or gastric juice of the stomach. Okay, and the mucosa, in addition to sort of being occupied with making gastric juice, it's also occupied with making an alkaline mucus. So most of the mucosa, so generally, is making this alkaline mucosa, or mucus, I should say, whereas inside those gastric pits, within gastric glands, will meet cells, and some of those cells are actually making an acidic mucus. Okay, so be aware that it all depends on where we are in the stomach mucosa as to what kind of mucus is being made. But because the bulk of the mucosa is making alkaline mucus, this mucus acts as a buffer between the crazy low pH of stomach acid and the delicate mucosa, the actual cells that we want to protect. We don't want to digest ourselves. So this alkaline mucus is protecting us from digesting our own stomach wall, and it's rich in bicarbonate, which is going to act as a buffer. So here on slide 9, we're seeing the general mucosa, all right, flush with sort of the the stomach wall, and that, of course, is making that alkaline mucus, but it's interrupted by these little pores that are called gastric pits. Wow, I just made it look kind of like skin. Almost looks like there are hairs growing out. That's extra gross. And then sort of this pit that's established, the base of the pit is occupied by a number of different types of cells that collectively comprise a gastric gland. So here's one gastric gland. Here's another gastric gland. Okay. Moving on to slide 10. There are 4 main types of cells in gastric glands. They include the mucous neck cells, the parietal cells, the chief cells, and the enteroendocrine cells. Mucous neck cells, they make, obviously, mucus. However, their mucus is relatively thin. It's not very viscous, and it's acidic, right? Whereas mucus being made at the more sort of shallow surface of mucosa is, again, alkaline, okay? So we actually end up with more alkaline mucus than acidic mucus. But certainly we want the environment within our gland to be acidic, and we want the environment in the lumen of the stomach to be acidic. So that's where part of that acidity comes from. Our parietal cells do 2 things that are both very important. Our parietal cells are responsible for really creating a situation that facilitates the formation of hydrochloric acid, HCl. And HCl is the primary reason why we have a very acidic lumen. That acidity helps to denature proteins, certainly proteins that we've ingested, with the aim of claiming those amino acids, but also proteins in bad guys. So the acidity certainly helps establish the stomach as the pit of despair. That HCl also helps to activate pepsin. We'll come back to that. Pepsin. And starts breaking down cellulose in plant cell walls. Unfortunately, we can't fully digest cellulose all by ourselves. So thankfully we have beneficial bacteria in our gut that are going to help us do that. But we'll come back to that. And then the other big job of the parietal cells is to produce intrinsic factor. And I may have mentioned before that if you had no stomach at all, if we removed it from you, chances are you would survive. But the one aspect of the stomach that would threaten you most, or the one aspect of not having a stomach that would threaten you most, is that you wouldn't make intrinsic factor. Your stomach is the site of intrinsic factor production. More specifically, your parietal cells are the site of intrinsic factor production. And it's thanks to intrinsic factor that we can successfully absorb vitamin B12 across the wall of the small intestine. So we've talked about intrinsic factor briefly before when we were talking about pernicious anemia. So parietal cells, HCl, and intrinsic factor. Our chief cells also have 2 chief or main products. Pepsinogen. Chief cells make pepsinogen, which is an enzyme, but it's inactive. Pepsinogen is the inactive form. And pepsinogen is activated to pepsin. So the activated form of the same damn molecule is called pepsin. And I just finished mentioning that HCl activates activates pepsinogen into pepsin. So once pepsinogen is exposed to HCl, really in the lumen of the gland, okay, it will be activated to pepsin. Also, pepsin will in turn activate pepsinogen. So pepsin being present in that lumen also helps to activate pepsinogen. Lipases are another product of the chief cells, and ACE is an ending that we often apply to enzymes. Lipases help to digest lipids. However, we don't make a huge contribution to lipid digestion in the mouth, and we don't make a huge contribution to lipid digestion in the stomach. Only about 15% of lipid digestion happens in the stomach. The bulk of lipid digestion happens in the small intestine, specifically in the duodenum, but we'll come back to that. And then the fourth type of cell that we can find in gastric glands are the enteroendocrine cells. And enteroendocrine cells produce, as you might guess, hormones and cell signals, including serotonin, histamine, somatostatin, and gastrin. Serotonin, histamine, somatostatin, and gastrin. And we'll sort of address what those hormones are going to do, what effect they're going to have on digestion as we go. For now, we're going to move on to the next slide, where we can better see at least some of those specialized cells. So here in the blue, slide 11, here's a parietal cell, which again is responsible for setting the stage for HCl production, as well as making intrinsic factor. At the base of the gland, we can find oodles and oodles and oodles of chief cells. Chief cells, again, are going to be making lipases and pepsinogen. Okay. Also, deep within the gland, you can find a few enteroendocrine cells, which again are going to make cell signals like serotonin, somatostatin, histamine, and gastrin. Whereas if we go back for just a second to slide 10, you'll notice that the mucous neck cells, they tend to be less deep. And that's actually why they're called mucous neck cells, because they're sitting primarily in the neck of the gland. Okay, so moving on to slide 12. Why do we need an alkaline, bicarbonate-rich barrier constantly lining the stomach? Because the lumen of the stomach is highly corrosive, which is ideal for digestion and denaturation, and also operating as a pit of despair. But it's also not so ideal because we are at least threatened by the possibility of digesting ourselves. And so that mucus that lines the stomach is very important, and the barrier that is established is actually not just thanks to mucus. It's also thanks to especially abundant tight junctions between the epithelial cells, between the simple columnar cells that make up the stomach mucosa, that prevent that really corrosive gastric juice from penetrating the wall of the stomach. Also, we replace our mucosa very, very rapidly. We replace the stomach mucosa over the course of every 3, 4, 5, or 6 days, so that epithelial cells aren't allowed to become so damaged that they can be easily bypassed by those corrosive conditions. Moving on to slide 13, just a list of the things that the stomach does for us. Obviously digestion, but remember both mechanical and chemical. The stomach acts as a storage tank, so that our small intestine and just subsequent alimentary canal isn't getting huge batches of food all at once. It's getting a little bit at a time, a little bit at a time, a little bit at a time. And if it's only having to manage a little bit of foodstuffs at a time, then it can do a more thorough job. So the stomach it's a bit of a storage tank. And in fact, our foodstuffs stay in our stomach. Usually, it does vary by both type of food and size of meal and consistency, like texture, if you will, of meal, but also varies by health, right? Some of us have Crohn's disease, some of us have celiac disease, some of us have irritable bowel syndrome, and some of us are just more prone to flushing the stomach faster or flushing the stomach more slowly. But on average, foodstuffs stay in our stomach from anywhere to 2 hours up to 6 hours. Okay, the stomach is responsible for managing chyme delivery a little bit at a time to the small intestine, specifically the duodenum. The stomach is responsible for denaturation of proteins, which is part of chemical digestion, but it's also part of its sort of pit of despair aspect. The stomach is responsible for, more so than any other alimentary canal organ, for the digestion of proteins. We do more protein digestion in the stomach than anywhere else. It's sort of like the digestive specialty of the stomach. We use a variety of proteases, enzymes that digest proteins, to break down different types of proteins and different sort of caliber of proteins. When we're infants and we're consuming only milk, possibly breast milk, then the chief protease that we produce is unfortunately called renin, not to be confused with the product of the kidneys. I'm sorry about that. Ew. No fun. The stomach, believe it or not, does participate somewhat in absorption. Specifically, we absorb lipid-soluble substances like certain drugs and alcohol across the wall of the stomach, and so that's sort of one of the explanations for how we can feel those effects relatively rapidly. And then recall that arguably the most important function of the stomach is the production of intrinsic factor to facilitate the absorption of vitamin B12. On to chapter 14. Your stomach mucosa secretes more than 3 liters of gastric juice every day. And so, yes, we take in a fair amount of water, if you will, via ingestion and drinking and such, but via saliva and obviously via gastric juice, also in the small intestine, in the at least beginning of the large intestine, we're adding so much water to our foodstuffs, and so the majority of the large intestine is very much so occupied with reclaiming that water. Because if we were to eliminate all the water that we add along the way, along the journey of the alimentary canal, then we would desiccate in nothing flat. The gastric secretion activity, how active those cells in the gastric glands are, is regulated hormonally as well as via the nervous system. And it's primarily the vagus nerves, which you're probably already aware of, that help to stimulate secretion. And when we're maybe stressed or excited or exercising, then the sympathetic avenue will inhibit secretion where the nervous system is concerned. And from a hormonal standpoint, gastrin is the chief hormone that stimulates, I should actually not underline that portion rather. Gastrin is the chief hormone that stimulates stomach activity, stimulates gastric secretion, okay? In the small intestine, however, we're going to see cell signals being secreted that quiet the stomach, inhibit the stomach, okay? So gastrin stimulates stomach activity. Some small intestinal hormones, which we'll meet when we get there, inhibit stomach activity. Moving on to slide 15. So gastric secretion occurs in three main phases: the cephalic phase, the gastric phase, and the intestinal phase. Well, the cephalic phase, I don't need a separate slide for, because it's very easy to understand and explain. It's reflexive, and it's simply sort of getting the motor started via really your cerebral cortex. So your cerebral cortex is stimulated by sensory input. Maybe it's odorants, maybe it's tastants, maybe it's seeing something yummy, maybe it's just thinking about Pringles. That starts that cephalic phase. Okay, cephalic phase, I'm moving on to 18, is followed by gastric phase. And the gastric phase alone will often last for 3 to 4 hours. It will yield about 2/3 of the gastric juice that we secrete. So very productive. And the gastric phase is stimulated by distension. So when stretch receptors in the stomach wall are stimulated by fullness, that sort of drives the gastric phase. Also, the presence of partially digested proteins will stimulate the gastric phase. The presence of caffeine will stimulate, everything ever. An increase, I should say, in pH, which means a move toward more basic or alkaline conditions. It also means that hydrogen ion levels are dropping, will stimulate the gastric phase. And then ultimately, these conditions, distension, the presence of partially digested proteins, caffeine if we consume it, rising pH, maybe the meal that we're delivering is not very acidic, that sort of thing. They all promote the secretion of gastrin, okay? And gastrin tells our parietal cells, hey, let's form HCl, okay? Gastrin will bind to gastrin-specific receptors on parietal cells and also bind to enteroendocrine cells and trigger those to secrete histamine in particular. Histamine will also help to promote the gastric phase. The proteins that we ingest will often cause pH to rise, although we've just mentioned that. And obviously that helps to promote gastrin secretion, and gastrin helps to stimulate the gastric phase. It's kind of nice that the gastric phase is stimulated by gastrin. They're just such similar terms. Whereas the gastric phase is inhibited often between meals when the conditions of the stomach lumen become especially acidic. We also inhibit the gastric phase whenever we sort of turn on our sympathetic nervous system. Moving on to slide 17, the intestinal phase is arguably a poorly named phase. So this is a phase of gastric secretion. Let's put that on the slide. Even though it's called the intestinal phase, what are we addressing here? The stomach. Okay. And the intestinal phase starts with a stimulatory period that's quite brief and follows up with a more lasting inhibitory phase. That stimulatory phase occurs just as the stomach is starting to send foodstuffs, chyme, really, into the duodenum. Okay? This causes the small intestine to secrete gastrin. So not only does the stomach release gastrin, but the small intestine can release gastrin. And yes, sure enough, in the small intestine, there are enteroendocrine cells as well. Okay, so they're producing gastrin, which says very, very briefly, go, stomach, go. Okay, but as soon as that small intestine is descended, is experiencing a decrease in pH, is experiencing a high input of lipids, and or is receiving a solute-rich chyme, which remember is more often written with a Y. The small intestine will say, no, stomach, no, that's enough. That's enough. And it will primarily utilize the hormones called secretin and cholecystokinin to signal the stomach to take a rest, inhibit its secretory activity just for now, until the duodenum empties and we sort of start the whole thing over again, even though it's the same meal. Okay? Well, The reason why we want to inhibit gastric secretion, especially during this intestinal phase, is because we don't want the duodenum to be overfilled. It simply won't do its job well if it doesn't have access to the molecules of chyme. And we don't want to expose the duodenum to excessive acidity. So just a little bit at a time, and we'll come back to that later too. The next slide, slide 18, is an overview of our different phases. The cephalic phase is stimulatory. The gastric phase is stimulatory, and one of the chief cell signals involved here is going to be gastrin. Okay. The intestinal phase starts with a stimulatory period that's very brief, and then sort of the rest of it is an inhibitory period that's longer, and that inhibitory period is driven by cell signaling from the small intestine. Primarily, those cell signals are secretin and cholecystokinin. We're moving to slide 19. And slide 19, we've actually seen this table before. In fact, it's on slides 19 and 20. It's just so large it doesn't fit on one slide. And now we can see some of the things that we've discussed sort of popping out of this table. The first time we saw this table, it really didn't do anything for us. But now it's starting to look familiar. Cholecystokinin, we just talked about being a product of the duodenum. It's stimulated by the arrival of partially digested proteins. It's stimulated by an increase in how should I say this? I'll say an increase in acidity. Also an increase in lipid-rich chyme and distension, okay? And this hormone targets the stomach and specifically inhibits gastric secretion. We've also talked about gastrin. Well, gastrin's actually produced in two primary places within the alimentary canal. There's sorry about this. There's gastric gastrin, meaning the gastrin that the stomach itself produces, okay? And gastrin is produced in response to really the arrival of food. Partially digested proteins will stimulate the release of gastrin. Distension will secrete the release of gastrin in the stomach. Specifically, the portion of the stomach that's targeted are the parietal cells, and gastrin is stimulatory. It increases HCl secretion, okay? Histamine, which is made in the stomach, specifically the enteroendocrine cells are releasing histamine when triggered to do so. It's stimulated by the presence of food in the stomach. It targets the stomach, even though it's also produced by the stomach. And it is also stimulatory. It tells parietal cells to facilitate HCl production. So it's very, very sort of overlapped with gastric gastrin. We also make intestinal gastrin. The duodenum in particular will produce gastrin. And gastrin, no matter what, is going to be stimulatory. Okay? But if it's gastrin produced by the duodenum, then the stimulus is going to be the presence of foodstuffs in the duodenum. So distension, acidity, partially digested proteins, that sort of thing. But still, the target is the stomach. I'm moving on to slide 20, which is really the same table. And there's yet another term that we've already run into here, the term secretin. And secretin, along with cholecystokinin that we talked about on the previous slide, is a product of the duodenum. It's secreted also when foodstuffs are arriving to the duodenum or shortly thereafter. It targets the stomach and it is inhibitory. Both cholecystokinin and secretin are inhibitory, and again they're made in enteroendocrine cells, but this time enteroendocrine cells of the duodenum. Okay. All right, I'm going to move on to slide 21 so that we can learn how hydrochloric acid is made. Okay, so in this particular image on slide 21, we're zoomed way in. Here is not just the stomach lumen, but the lumen of a gastric gland. Okay, and this crazy guy here, blue, is a parietal cell. And this parietal cell will take in CO2 inside the parietal cell with the assistance of our trusty old wingman, carbonic anhydrase. CO2 will combine with water to produce, what's that? Carbonic acid. Carbonic acid, as you already know, is unstable and will dissociate into bicarbonate and hydrogen ions. And this time around, rather than sort of being concerned about transporting bicarbonate, our aim was to isolate these hydrogen ions, okay? And so the parietal cell will send these hydrogen ions out, really pump them out by exchanging for another positively charged ion, potassium. Okay, so that there's no bulk change in membrane potential. And in the meantime, the parietal cell is also pumping in chloride ions, and it shunts those ions all the way through from basal surface to apical surface. Okay, it shunts those chloride ions all the way through, so that it's actually in the lumen of the gastric gland that hydrogen ions and chloride ions combine to form HCl. So technically, HCl isn't made inside parietal cells. It's made with facilitation, guidance from parietal cells. Okay? Moving on to slide 22. I think, yes, 22. All right, we talked about gastric secretion. Now we're going to talk about gastric motility. So what is the sort of muscle of the stomach doing when and why and all that sort of thing, okay? We already know that when the stomach fills, it will distend or stretch, okay? And the pressure within the container of the stomach, because it's so stretchy, it actually remains fairly unchanged until we fill it up to a little over a liter or more. And we move motility. We move foodstuffs around in the stomach in response to that pressure change, using peristalsis that begins near the cardia of the stomach, so near the gastroesophageal sphincter, and at that sort of end of the stomach, this peristalsis is really, really gentle. So we're just getting like gentle ebbs, gentle rippling, okay? But as we approach the pylorus, as we get closer and closer to the pylorus, these peristaltic contractions become stronger and stronger and stronger. And the pylorus, the pyloric valve, will only allow liquids and small particles to pass through. It will, via the force of peristalsis, squirt, grows only about 3 milliliters tops of chyme into the duodenum at a time. Anything that's a particle that is too large simply won't pass through. So small particles and, of course, liquids. The contraction, the peristaltic contraction that's increasing on its way to the pylorus of the stomach, it actually triggers, certainly on delay, but it triggers the closure of the pyloric valve. And as a result, the remaining chyme inside the stomach will literally bounce off of the pyloric valve, which is called retropulsion. And that bouncing just sends the chyme back into the heart of the lumen, and also helps to mix, okay? The strength of our peristaltic waves in our stomach, it can vary, but the rate of the peristaltic waves in the stomach doesn't. Those wave-like contractions, they occur at the same rate no matter what. They don't necessarily occur at the same strength no matter what, okay? And that rate is set by the enteric nervous system. We have pacemaker-like cells in the enteric nervous system that establish that peristaltic rate, okay? Moving on to slide 23. We've talked about gastric secretion. We've talked about gastric motility. We need to talk about gastric emptying. And again, the overall time that it takes to empty the stomach after consuming a meal, after ingesting a meal, it can vary so much. 2 hours up to 6 hours, but even that is, we can play with that window, certainly. But sort of a nice average-ish is 4 hours, okay? What's surprising is the larger the meal that we consume, the faster we empty the stomach. And the reason is that we're actually providing a larger stimulus. We're distending the stomach that much more. We're stretching it out that much more. And so we're really churning out gastrin and speeding the stomach up, okay? We empty fluids faster than we empty solids, because solids have to be broken down into small enough particles to pass through the opening of the pyloric valve. But also, what's housed or contained in the duodenum can influence how quickly we empty the stomach, because we have stretch receptors in our duodenum. We also have enteroendocrine cells in our duodenum, and when our duodenum is especially full, we can, especially via chemical signals, reduce the force, reduce the strength of peristalsis in the stomach and sort of quiet it down, which isn't surprising, I hope. When we consume a meal that's rich in carbohydrates, that meal is likely to move through the duodenum, not the stomach, the duodenum, faster. And that means that we're going to, in turn, empty the stomach faster, okay? Whereas if we consume a meal that's rich in lipids, the duodenum will need more time to digest those lipids and will hold on to that chyme longer, and therefore the stomach will empty more slowly. And if it's especially fatty meal, then we're likely to leave it in the stomach for more than 6 hours. Moving on to the next slide, which is actually our last one, slide 24. Just showing us the different factors visually that influence gastric emptying. So just in case you're a visual learner, or you like to put everything you learn all in one place, one visual place, that image is handy.